Well, good morning, everyone. This is Professor Dunham, and I am here today to discuss Chapter 12 with you. That's on the term newborn. So let me go ahead and share my screen with you, and let's get going. All righty. So during week 7, we're discussing the term newborn, and here's our beautiful newborn. Okay. So, they've been living inside of mom called intrauterine life for the past 9 months. And now mom's body, is now going into labor and is going to push that baby out. So now this newborn has to adjust to life outside the uterus, and that's called extrauterine life. All right, so his adjustment depends upon maybe mom's genetic background, the health of the recent uterine environment. Okay. Over the past few weeks, you might have heard me say that baby's in what we call a hostile environment. That means that the environment wasn't really conducive, wasn't really great for growth. And then we want to ensure we have a safe delivery. Okay. So we want to, the first month of life is so very important. So what we worry about when these babies are born is breathing. So respirations, they are started due to like chilling and chemical changes in the blood. Okay. Remember, he's coming out of a nice warm environment and coming into a cold environment. What I always say, have the radiant warmer ready. So you have some sensory and physical stimuli. And he takes that first breath. Oh, so important, because the first breath opens the alveoli. And then you have independent, that means on his own, excuse me, air exchange begins. And then all of that starts the cardiopulmonary functioning. So during, we had to adjust because now everything is going to be having to work, but everything is immature. And even the digestive system is immature. Because there is a deficit in the enzymes from the pancreas and liver. The kidney's ability to concentrate urine and maintain fluid balance is limited due to decreased rate of the glomerular flow and limited renal tubular reabsorption. And then, everything is there, but they're immature, or you may say primitive, even the neurological functions. Everything is going to start developing even greater on the outside. So we had phase 1 of the newborn. Now we have phase 3, the care of the newborn. So when you observe the newborn, the nurse identifies expected normal findings as well as variations and deviations from the norm, which must be reported to the healthcare provider. So I always said, know the normal vital signs of the baby, okay, so that you can recognize it and report when things are abnormal. Because the sooner you report things abnormal, then we can get that baby health and avoid major things. So let's start with the nervous system, reflexes. So reflexes are very important to the baby's survival. And Hesse will say to you on the test, they'll have some questions about that. And so you want to make sure that you know these reflexes, which help keeps these baby alive. You have the blinking, you have the sneezing, the gagging, the sucking, and the grasping. The gagging reflex is so very important because the baby gets a lot of mucus and he's not able to bring it up to gag and get it up. he could aspirate on that. Now reflexes continue. We have the Morrow reflex, which is the startup. So what happens is maybe you got the baby in that little baby crib and you go around a corner, and you hit like maybe the side rail or something, and the baby will flange up. He'll flange up, his little arms go up in the air, and that's a startle reflex. That's all very good because, again, that's the neurological system, and it's working. It's working very good. Now you got the rooting. So anything that touches the cheek in anticipation of food. Okay, so I would definitely know these reflexes. So if you have your notebook or you have your textbook out, go ahead and highlight rooting. Again, rooting is a reflex that helps with breastfeeding. Think about that. Okay. Then you have the tonic neck, which is a postural reflex that is something assumed by a sleeping infant. Oh yeah, they're really flexible. One part of the body is out with his arm up, and the other part is, your picture has a really good, your textbook has a really good picture of it. And then you have the dancing reflex, which is like prancing movements of the legs. So like his foot touches a cold surface, and so his reflex is what? Ooh, that's too cold, get it up. Okay, so he brings up the foot. Then he goes his other foot, he pushes it down, he goes, ooh, it's too cold. So that's a good reflex. Again, reflexes protect us. Just think of yourself. If you are cooking and you open up your oven and you touch a little bit of that inside the oven when it's been on, like have an oven on like 350, that's kind of hot, and you touch it, what is your reflex? Your reflex is to go bring that back, right? So same thing. That means that your brain, your neurological system is working because it senses that that's too hot and it gets you out of danger. These are the same things that an infant that's just been born has these reflexes. So if I was to ask you, which newborn reflex would the nurse teach to the mom when starting to facilitate breastfeeding? Okay, see, that's a really good question. I would go ahead and write that down. And then it's rooting, ROOTING. Now let's talk about the head. Okay, so thank goodness our babies are born where their head's able to mold down in the pelvis for delivery. Now, since those soft tissues, they really are soft, right? They can get a little swelling down in the passageway. And so when a baby's born, he has swelling on the back of his head. It's called a caput, okay? And that's just fluid underneath there, okay? That's called caput, C-A-P-U-T, and I call it succedaneum, S-U-C-C-E-D-A-N-E-U-M. And that one, because where it's positioned on the, let me show you here, that's because it's positioned in the back of the caput part of the crown in here, that it crosses the suture line. So your suture line goes down the middle, okay? And this here is swelling, and it's swelling that crosses the suture line. Okay. Another swelling that I want to discuss with you of the head is called a Cephalohematoma. Okay, so you can see that word, take it apart, that's like a blood underneath what? The scalp, the cranial bone, beneath the periosteum. Okay, and what that is, okay, that one does not cross the suture line. So those are good questions for tests, by the way. So a cephalohematoma, okay, cephalo's head, and hematoma is collection of blood. That would be in the side of the head, right around in here, okay? All right, I'm showing you that so you have an understanding the difference. And this one would not cross the suture line because the suture line's up here, goes down the middle of the head. All right, so that's over here. So that doesn't cross the suture line. It's the Caput Succedaneum that is back in here that crosses the suture line. Again, that's really a good test question, and I would take note to that. All right, again, fontanelles, they're little soft spots, and they protect the head during delivery, and they allow for further brain growth. They will close, anterior and posterior will close during the first few months of life. Okay, so if I was to ask you a question, which of the following assessment of the newborn's head describes the swelling of the scalp if it does not cross the suture line? Okay, so that's how the questions could be asked to you. So if it does not cross the suture line, that means it's on the side of the head, right? And that would be the cephalohematoma. Okay, and here you go. This is just a picture of the baby's skull. And here you have the frontal bone and you have the frontal fontanelle. And you can see the occipital bone and you have the temporal bone here. Okay, just take note to this. And this is a really good picture. It shows you the occipital fontanelle, which is the back of the head. It looks like a crescent, you know. And then here you got the suture line coming down the middle of the skull, and then you have the frontal fontanelle, which is right here. And it looks, it's a diamond shape. It's bigger than this. All right. All right. Let's go ahead now and talk about his little ears. Okay. They are small, like I just said, they're little, but they are there. They're well developed. And hearing ability. Hearing ability is present at birth as long as the baby's not sick or premature. So they able to, a term baby is able to hear at birth, and that's reassuring to mom. Now, they will have some normal drainage and sneezing because the body, the ear, wants to get that fluid out. So it wants to get rid of those amniotic fluid down in the ear canal. Okay, so that's common, sneezing. Again, that's one of the reflexes. And so, again, that has to get the fluid out. And then the ears may react to sudden sounds by increased pulse and respiratory rate. Or, you know, that startle reflex, you know, you get scared. He has a startle reflex that could increase his pulse and respiratory. But again, it's reassuring to mom that her baby's able to hear. And then the baby responds to voices by decreasing motor activity, sucking activity, and turning head toward the sound. That's how a lot of times in the labor room, in the delivery room, LDR, we can actually observe the baby hearing because the baby turns his head toward the sound. He stops what he does, you know, and he goes, oh, what's that noise? Oh, okay. And he does. So that's reassuring again to mom. But on all babies, before they leave the hospital, we will do a hearing screening. Now, your visual stimuli and sensory overload, they can see and they can fixate on points of contrast. So that's why, you know, the toys with like these colors, contrasting colors, they attract the newborn's attention. And you want to stimulate these babies, not to be overloading them, but just to, you know, train the eyes. Now, the tears, this is interesting. Tears are absent until 1 to 3 months of age. So that's why you have to be very careful with their eyes because they don't have that liquid that you and I have and can produce tears. Now, sensory overload can occur if there's just too much detrimental stimulation. Like I said, you don't want to have him too stimulated because then he'll never sleep. Babies have to sleep, and when they sleep, they grow. And when you sleep, you know, your body, you know, recovers from the activity during the time that they're awake. So you want them to make sure that they don't get too stimulated. And it's always important for the nurse to keep surrounding environment as calm and quiet as possible. Yeah. I mean, at a hospital, we have a lot of bright lights and loud alarms, and that used to be the way. But now, even the NICUs they have more private rooms than they have a big room with all of these isolates in there. So, because over the years, research has shown that these loud alarms don't allow the baby to go into a nice sleep. Okay. And so you want him to have these sleep cycles, and they sleep from 15 to 20 hours per day. And they have phases of their sleep. Wait. Just a minute here. We're just going to tone that down. Okay. And 15 to 20 hours per day. And they have the phases of the sleep-wake cycle. Okay. So you have him first reactive, then he goes to sleep, and then he has another sleep, second reactive, and then he'll get stable. Now, these are kind of neat because these are patterns of activity that can influence the response of stimuli and bonding. Bonding is very important. We do that right after birth, skin to skin, the best way in breastfeeding. And you want that to happen because that, for psychological reasons also, is very good for the child as he grows up. And you want to have some quiet sleep, all right? That means it's nice and quiet, baby sleeping, because you want him to go and have a REM sleep, which is your deep sleep, because again, babies are growing, mother's sleeping. And then he wakes up, and he's looking all around. So that's called an active alert. Okay, he's awake. He's letting you know, I'm here, mom. Okay. But the quiet alert is, this is the one that he kind of looks around and he's checking in everything around the room, you know. And it's kind of nice because they're just looking. They're curious and looking. And then he's going to let you know. Babies communicate to you through crying. Okay. So those are all really good little sleeps. Now, pain. Do babies actually, neonates, experience pain? And I'm here to tell you, yes, they do, because they produce the catecholamines and the cortisol. Their heart and respiratory rates will go up, will change. Blood pressure increases as does his blood glucose levels. Okay. And if pain is not treated, you know, you can have some long-term effects. You know, he's got a brain, you got a memory in there. So, you know, you want to make sure that we're addressing his needs. So the pain pathways and structures required for long-term memory are well developed by how many weeks? 24 weeks gestation. That means inside mom's womb. Okay, that's like 24 weeks. And then unrelieved pain can cause baby to be very tired or exhausted. Irritability is a big one. And then, of course, delay in any kind of growing or healing process. So we do have some pain assessment tools, and they are in your book. Go ahead and look them up. And I put a couple here for you. One is called the comfort scale, and it's a 7-point scale. And what we're looking at is, and a lot of these, this is where we look at the same thing: alertness, being calm. Is the baby calm? Muscle tone, facial tension. Do you see in his face that he's in pain? Heart rate. What's the heart rate doing? Is it going up? And then, of course, you can do a mean arterial blood pressure, and that would be up. Now, the cries is a 10-point scale. It kind of looks at the same things, except for a couple more. And then the FLACC goes over, you're looking at the face, again, alertness, same thing, the cries, legs activity, crying, okay? And can this baby be consoled, okay? And so, yes, babies do experience pain, and we need to be on alert to that, especially during the circumcision. Now, which acronym is often used to assess a newborn's pain? So if you look at this, you'd have to know this is group beta strep, SROM, spontaneous retromembranes, AROM, artificial, and then FLACC. Remember that one was right here: face, legs activity, crying, consolability. That's the kind of questions that you might get. Okay. So we have what we call conditioned responses. So, you know, you have them too. It's a responsive reflex that is learned over time. Anything over time is conditioned. So like my example here is, you have a hungry infant and he stops crying when he hears his mother's voice. Even though food is not available, okay? She's not going to feed him. He stops crying because mom is there. Mom is going to take care of everything for him. Again, it happened over time. His condition, that's his response. And emotions, they're particularly subject to this type of conditioning. Now, we have a neonatal behavioral assessment scales. And what this does, it measures inherent neurological capabilities and response to selected stimuli. So areas tested, okay, remember, going back to those pain scales, again, alertness, is your baby alert? Because this is about behavior, okay? Remember behavior. How is he responding to visual and auditory stimuli? Again, this baby's behaving. You want to pick these up because there's diseases out there that infants are born with that may throw off visual and auditory stimuli, may throw off his normal behavior in reaction to these. Okay, makes sense. Again, how is your baby motor coordination? How is it moving? Again, it's a behavioral. And then is he just laying there flaccid, just not moving? You want to make sure that you're looking into all this because, again, we have this behavioral assessment scale. And then the level of excitement, he should have some kind of excitement when maybe when he sees mom's voice or dad, he should be a little bit excited, not just laying there. Again, organizational processes in response to stress, okay? Yes, babies, I guess when we're born, we're just prone to experience stress no matter what. Respiratory system, let's talk about the lungs, okay? Because it's so important. So once the umbilical cord is clamped and cut, the lungs now take on the function of breathing oxygen and removing carbon dioxide, okay? It's like we always say, you cut the cord and you're on your own, baby. It's time to wake up and let's breathe, okay? And that first breath helps to expand the collapsed lungs. And that's why we say when we hear that first cry, because the cry actually helps very much to open up those collapsed lungs. Because remember, it's much different how he was breathing in utero, and then all of a sudden now he is, because during most of the time in utero, they're not even breathing, okay, because of the different shunts. And you don't need that because he gets everything from mom through what? The umbilical cord from the placenta. So he doesn't need it. About 37 weeks, though, they start to expand in utero. And so, we're on your own. You got to breathe. So that's why our assessment, that's why Dr. Virginia Apgar came up with that Apgar scoring, so that we'd be looking at respirations and heart rate. Now, full expansion does not occur for several days. Okay, that's why that first hour of life is so critical. And that's why the first hour of life, he's actually in the LDR with mom. The nurse is in there. And we're all, we're watching mom, watching baby, watching the bonding process, we're watching she's breastfeeding, we're watching how much fluid he can get out. We have to use the bowl syringe to make sure we get the fluid out of him. And so that's why it's always good to watch him very, very carefully. And the newborn should be positioned where? On his back. Because or his side, because you need a patent airway, no matter who it is. If it's a neonate, if it's a young child, if it's an adult, a geriatric patient, they all have to have patent airways. So this is a good one. What can be administered to a preterm infant to reduce symptoms of respiratory distress syndrome? Okay, we don't want our babies ever going to respiratory distress syndrome. So this would be something like for a preemie. Preemies, they have less of this because they're preemie, okay? Because surfactant, gets produced about 25 weeks. And so around that time, at 25, 26 weeks gestation. And so a preemie baby that maybe is born at 27, 28 weeks would not have enough of this. And that is the term called surfactant. Now, I want you to take note to this and write it down because you'll see it again. You need to prevent RDS, you need surfactant. Now, bowl syringe. Okay, so here it is right here, little blue syringe. And very important that we maintain the airway, not only through correct positioning of him on his back, like here, and removing any mucus from the mouth and nose with the bowl syringe. So we have the bowl syringe, and we're going to do the mouth first and then the nose. And when you put it in the mouth, please put it to the side, on the side, inside the mouth, not straight in. When you do it straight in, you're going to wake up, you're going to elicitate the what? The gag reflex. You don't want to do that, okay? Because the baby can really be choking on that, especially if he's full of fluid. You want to get the fluid out of him. So put it on the inside his mouth, on the side, okay? Very important. Now, that would be a really good test question. So, again, you've had this in last chapters. It's just a standardized method of evaluating newborn's condition immediately after birth, and that's APGAR scoring, and that's by Virginia APGAR. And what she wants us to do, as healthcare providers right after birth, she wants us to look at the heart rate. Is it below 100 or greater than 100? Is respirations, is it greater than 30 or less than 30? You know, how's he breathing? Okay, because that's so important. Muscle tone, reflexes. Did he able, when you took your finger on the sole of his foot and his little toes should what? They should fan out. That's called a Babinski reflex. Did that happen? Okay, that's important. And the last one is color. And color is important because it tells us a lot if his circulatory system is working. Remember, when he's born, it's going to be different than what it was in utero. It's going to be opposite. The shunt's got to close, and blood has to be rerouted, all right, through his body. So it takes a little time. So normally, we give him an APGAR score. We give him a 1 if he's got a pink trunk and like his face is pink, okay? And that would be 1. And then you take off a point for the color on his extremities, like his hands and his feet. And that's called acrocyanosis. And, you know, it takes time to get out to the peripherals. It takes time. It makes sense because things, again, are getting rerouted in there. And so, and that's just 1 minute at birth. Now, usually by 5 minutes of birth, you can see, you know, some pinkening up of the extremities. But, you know, you got to be careful and make sure, and you only give it 2 if his hands and his feet are pink, along with the trunk. That's a good way to really assess very quickly what level of resuscitation that you need to do. Now, our score is done at 5 minutes after birth. That's the APGAR score. And we monitor for respiratory distress. Now, this is really important for you to write down because I know you're going to see this again. So you're looking at his respirations. What's the rate? Okay, remember, normal respirations are from 30 to 60. So what's the rate? And then the character. Is he pulling? Is he breathing okay normally with inspiration and expiration? Or is he having some what we call retractions? Okay, color. Okay, so we're looking at the color of him. We talked about cyanotic. And then general behavior of the baby. How's the baby? Is he moving around? You know, the reflexes, remember, the muscle tone, or is he just laying there, flaccid? Okay. Now, sternal retractions. Okay, so you can see a baby sternum, and you can see actually when this happens, you can actually see that the sternum kind of retract in. That's because he can't breathe, all right? And he's trying to communicate to you, I'm having a really tough time in here. I'm not getting my oxygen that I need, and he's really pulling for the air. So that is awful. Sternal retractions, and they must be reported immediately to the physician. Now, you probably see that one again, so I would definitely take note to sternal chest retractions. Always not good. So please go over this again, okay? Because it's important not only for maybe your quiz that's next week, but also what else? Okay, exam number 3. All right, so here's another brain teaser. What symptom assessed in the newborn shortly after delivery should be reported immediately? Okay, and if you look at here, you know, I would say sternal or chest retractions. Great, there it is. That's the kind of question that you could get. So take note to that, because you may see cyanosis, but read on of the hands and feet. Well, you know, that's normal. Okay, that's okay. You may read and say, oh, look at there, mucus draining, but read on, mucus draining from the nose. That's okay. He's getting the fluid out of his nose. And then irregular heart rate of 150, but remember, it goes from 110 to 160, so we're still good. And the heart rate would be a little irregular, so at birth. So this is the one you would keep an eye on this, of course, but this is the one which tells you has to be reported immediately. So that's how you have to look at these test questions, that you have to read them fully. Okay, you have to ask yourself, what is this question actually asking me? It's asking me what symptom should be reported immediately, and should be here, sternal or chest retraction, because this baby, it's just been born, is in the newborn is shortly after birth. That tells you when it happened. So that's how you have to take it. Just don't look down and say, oh, that's cyanosis, that's not good. Look at it, okay? All right. Now your circulatory system, there's about 300 mLs of circulating blood volume, okay? I mean, this is a small little guy. And the neonatal circulation, we talked about this already, difference from the fetal circulation. And it depends, his circulatory system depends upon the ducts. Remember those 3 ducts within the heart to close at certain points in time, such as, remember the foramen valley, the blood goes from the right atrium to left atrium of the heart through the opening in the septum. Well, that has to close. And then ductus arteriosus, remember some blood from the pulmonary artery to the thoracic aorta by way of ductus arteriosus. So those are things that you could review if you need to on the 3 different shunts. So what happens now? Your baby's born. So if the ducts fail to close when they are supposed to, then the neonate may become cyanotic, because the blood now is still bypassing the lungs and does not pick up any oxygen. Everybody needs oxygen, okay? Blood, everybody needs blood, and blood, you have oxygen. So if these shunts don't close like they should, then you're going to have the same kind of fetal circulation that you had in utero, but it's not going to work because he's not getting any blood from the placenta through the umbilical cord. So it doesn't work that way anymore because he's outside of mom. So this is where a lot of times we pick up in the nursery, actually, when we see the baby starting to get bluish around their mouth, they become cyanotic because, again, they're not getting the oxygen it needs. Okay, kind of makes sense. Think about it. All right, now going to go on to providing warmth. I know I've spoken about thermoregulation before, and babies have an unstable heat regulating system. Remember, everything is there, but it's not mature. Okay, so you're going to provide the warmth. You're going to have your radiant warmer in the delivery room ready to go. Okay, and so not just in the room, plugged in, turned on, and ready to go. I always have my warm blankets in my delivery room. Okay, ready, you know? I mean, just think when you come out of a pool, okay, and there's like a chill in the air, all right? Don't you get like shivers? You mean, don't you get really cold? Same thing happens to baby. Baby's coming out of his little pool that was mom's inside mom uterus, the womb, and now he's outside. He's going to have cold air around him, and he's wet. He gets cold very, very easily. Again, now that acrocyanosis, we talked about it, is there because of the sluggish peripheral circulation. We talked about that. And he just cannot adapt to changing temperature easily. No, nobody can. Okay. Once you get chilled, ever been down with cold? And once you get really, really cold and you get chilled, it takes, even though you're coming into a warm environment, it takes time for your body to regulate itself. Same thing with a baby. Okay. So, really sit down, take your time, read about it, think about it, but it's the same phenomenon. Now, sweat glands do not function during the neonatal period, which is that first month. So infants are at risk for developing elevated temperatures if they're overdressed or they're placed in an overheated environment. Yeah, I talked about giving them warmth, but you can also overdress a baby, okay? So, and babies, they have a hard time because they don't sweat. And so then they could be overheated. Not good for a baby. So when you're obtaining temperature, pulse rate, and respirations on a baby, that temperature is going to be the last. Okay. And I know that when you do your vital signs on an adult, you always say the temperature first. Okay. And not on a baby, because you don't want to upset a baby. Okay. Because once you upset them, you're not going to be able to get the pulse and respiratory rates that you need. Okay. So you want to do your pulse and respiratory rates before taking the temperature. Infants may cry when disturbed. That kind of makes sense. They're laying there. Think about it. They're laying there in the little crib, and you have to take the vital signs. Okay. And you're going to do the pulse and respiratory rate, because then you can really count. I do the respiratory rates first, okay, because I can really count these little respirations. And then I do the pulse. I do an apical pulse, okay, for 1 full minute. Okay. And I usually do it very gently. And I make sure that my stethoscope is warm, so I don't put a cold stethoscope on his chest. And then when I'm done with that, then I can move on to the temperature. Okay. So I put here what you're looking for, your pulse rates. If it's greater than 160, that would be tachycardia. Less than 110 would be bradycardia. And then you have respirations greater than 60 or less than 30. Again, noisy respirations, those are called what we call grunting. Okay. So, when you're looking at a baby, your tachypnea, which is fast respirations, is not a good thing, right? Sternal retractions are not a good thing. Okay. And so, you want to pick, be sure when you see a test question, make sure that both the choices and the answer are what you want. Okay. Because sometimes they can throw you off too. All right. And nasal flaring and chest retractions are never good either. Never good. Remember? They need to be reported immediately to the healthcare provider. So this is another slide that goes over maintaining body temperature of the newborn. So we want to always keep the head covered, okay? Because head has a large surface area and is a really good source of heat loss in this baby. That's why you see the little caps we put on the babies. Yeah, because we don't want him to lose his heat. Now, you have remember the 3 ways of losing heat is convection, conduction, radiation, evaporation. So here you want to make sure you prevent any kind of baby in a draft, because a draft, they'll lose heat, and they lose heat by convection. Okay, so don't put him on under a draft, especially here in the South where we have heavy air conditioning and we have those air conditioning vents. Be real careful about that. And then do not place infant on cold surface because they can lose heat by conduction. So like you put them on that cold scale and the LDR, okay? We always put, it's a really thin tissue paper that we put on the scale first. And that's because we don't want to put his body on a cold surface because again, they would lose heat through conduction. And then do not place the baby near a window. Okay, so like, you know, and it's good for security too. I don't like babies' cribs by windows because they lose a lot of heat through radiation. Now keep infant covered at all times. Okay, so when a nurse does her assessment on the baby, you know, I'm not going to just strip him down to nothing, all right? Okay, so I'm going to have him in a warm environment and I'm going to, usually it's in the room, and right in front of mom, we do the assessment on the babies and we'll only expose the area that we're assessing. Okay, so if I'm only assessing, say, the left side of his body, I will keep the right side nice and what? Cover it up. Okay, all right. And that's kind of nice to keep them from getting a loss of what? Heat. I want to make sure that I don't lose heat. Okay. Because I tell you why, you write this down. You don't ever want to cold stress an infant. All right. Then keep the infant covered at all times. Okay. Expose small areas for diapering, like I said. And then the baby, the neonate, has small amount of subcutaneous fat. Yeah, he doesn't have much fat on him, and fat helps to conserve body heat. So, you know, that's why we have to help this guy because he don't have much. And then keep infant dry to prevent heat loss by evaporation. So when he comes out of that nice warm environment inside of mom, he's going to come into a cold labor delivery recovery room, LDR. You want to make sure that you dry him off, get rid of that wet blanket. And I have another warm blanket and I grab that and then I'm going to put it around my baby. Okay. And let's talk about his musculoskeletal system. Now the skeleton is flexible. He's pretty flexible. And see this little guy here. He's flexible. He's able to have one arm up here and one leg out here. And here he has one leg up. You know, he's in all kinds of positions. He's really flexible. Okay. And, you know, his movements are kind of random and uncoordinated. Yeah, he's not, you know, got everything going, but he's got things there. So what happens is everything is there and it has to keep developing. And that's what happens when they sleep. They keep on growing, keep developing in their muscles and their bones. Okay. And then the head and neck muscles are the very first ones that come under control. And you can see some really good, strong babies. If mom had a good pregnancy, mom took her vitamins, mom's healthy, no smoking, no drugs, no alcohol, you will see a baby come out and their head and neck muscles are very good. They're well, you know, they're well put together. Now, length and weight. This is just a slide that tells you about the average length of a baby. It can go from 19 to 21.5 inches, all right? And then average weight goes from 6 to 9 pounds. Well, I guess our 9 pounds now goes under average weight, but that's a big baby. Remember, that would fall under that macrosomic baby. And the first 3 to 4 days after birth, it is very common. Now, this could be a good test question. It's very common that the infant does lose about 5 to 10% of his birth weight. Okay. And the reason why, you think of why they're losing weight is because they're born with a lot of fluid. Okay. And they haven't got rid of that fluid when we first weigh them in the LDR, because everybody wants to know the weight of the baby right away. How long is he? And what's his weight? All right. So it's very, very common through the first few days, like 3 to 4 days, that he's getting rid of all that excess fluid. All right. And so therefore now his weight's going to go down. Just like you. If you take in a lot of sodium and then you're retaining a lot of fluid, okay, because most of our bodies are made of fluid. If you're retaining a lot of fluid, then as you don't eat that salty substance anymore and you drink your water, now you're flushing through your system, you excrete, you're going to put out a lot of urine. And sure enough, a lot of people say, oh, I lost a couple pounds. Yeah, you lost what we call it, water weight. Okay, same thing. And again, hormones also boost up their weight, just like women have estrogen in our body, and that kind of attracts fat, and that kind of puts our weight up. Same thing. But now the baby is out of mom, so now that baby doesn't get mom's hormones anymore, and so therefore they lose weight. There's some fluid shifts I talked about, and of course they're going to now be urinating regularly and pooping, so they'll have you lose, your body weight will go down because of that too. All right. Now, the kidneys in a newborn, don't forget, this is a chapter on term newborn. That's from 37 weeks to 40. So this is all about babies now during that time. And I guess you could put post-term in here too. And then kidneys are not fully developed at birth. Remember, everything is small. So the glomeruli are small. Then you have the renal blood flow, and that's small. I'll just say small, and it's about a third of an adult. Okay, and so the ability to handle a lot of water at load is reduced. So that's why breast milk is great for these babies, because it's easy not only digestive tract, but it's easy on the kidneys. So the kidneys can start to function better and have the ability to concentrate urine. Because I tell you why, these babies, they don't have right now when they're born, they don't have the ability to concentrate urine, and cope with fluid imbalances. They don't have it. So you have to make sure that you're breastfeeding every 2 to 3 hours to keep making sure this baby gets enough fluid. And how we know this baby gets enough fluid, he should have about 6 to 8 wet diapers per day. That's a good way. If it has less than 6 diapers, then you're thinking, okay, what's going on with the kidneys? All right. And even when mom has decreased amniotic fluid, when we pick up that's very low, then we're always thinking about what's going on with the baby's kidneys in utero. Okay, it all goes together. Now the male genitalia, the testes, they will descend into the scrotum before he's born, and we go ahead and test that when the male infants come out. And then location of the urethra opening should be on the tip of the penis, and we look at that, make sure it's right there, because if it's not, if it's off to the side, that could be a condition called hypospadias, and so that needs to be noted, okay, because it's not normal. So you want to make sure you note that, because you have to have surgery, and the skin that they can use to correct that would be the foreskin. Okay, so that would be something that we look at. And then they have a white cheesy substance, and that's called SMEGMA, and that's found under the foreskin. Just kept everything lubricated in utero. And then some parents, they may choose to have their child circumcised, while others may not. It might be culturistic, it might be religion, it might be just the parents decided not to circumcise their child. That's it. And whatever the decision is, you just do proper care of the male genitalia, so that they know how to retract the foreskin and clean underneath there, and so that there's no way in getting an infection. Now, okay, so we'll move on to circumcision. And again, that's just surgical removal of the foreskin on the penis. Okay, there are some benefits and there are some disadvantages. And the benefits, it does decrease the risk of penile cancer. Okay, there's some research on that. And so that's something to think about. See, when as a parent, you have to think about it. It's better to have the circumcision done as a neonate than it is to have circumcision done as an adult. Okay, I've taken care of a lot of men that had circumcisions later in life, and they had trouble. They had a lot of infections, a lot of pain associated with it. Okay, and then we have seen fewer UTIs in men that have been circumcised, and as they get older and they're having sexual relations, there's fewer sexual transmitted diseases. So those are things to think about. And then disadvantages would be to it, you have more infection and hemorrhage. Now, the hemorrhaging comes out from that vitamin K that, babies are not born with enough clotting factors. So, a lot of times now they'll wait like a week and have a mom come back into the pediatrician office, and the pediatrician will go ahead and do the circumcision. In the Jewish faith, they have a ceremony called the bris, B-R-I-S. And it's really beautiful, by the way. And the rabbi will actually do the circumcision. And it's very private. And it looks like a little altar that they set up in the home. And they have all the people, the head rabbis around the baby. And it's a very very nice ceremony, and a lot of prayers for the child, and then they go ahead. And they don't do that till like 7 days after the baby's born. Okay, they wait a whole 7 days, and that's because after 7 days, the baby starts to make his own clotting. See, and so way back in the days, they probably lost a lot of babies due to hemorrhaging because of circumcision. And they realized that if you wait 7 days, that normal clotting occurs, and the baby did much better. So it's kind of neat to go back in history and read about that. But no matter what, even in the hospital, or if it's in the hospital or pediatrician's office or in the home with a breast, babies have to be physiologically stable, okay, before you're going to try to do a circumcision. You wouldn't want to do a circumcision on a baby who's not well, that's having periods of respiratory distress or low blood sugars, things like that. You wouldn't do surgery on that kind of person, and you wouldn't do surgery. Think about it, everybody. You wouldn't do surgery on an adult who's sick, right? Who has unstable blood sugar, who has unstable blood pressure, who can't breathe. You wouldn't do that on an adult. That's why you don't do it on an infant. Okay. Now, female genitalia, their little genitalia can be slightly swollen because don't forget, they're going to get the hormones that mom's producing to baby. It goes right across the placenta, and so their little vagina is going to be a little bit different. They may have swelling. They have, white or blood tinged mucus that comes out of their vagina. And that's actually called pseudo menstruation. And that's just, again, caused by the hormonal withdrawal from the mother. Okay, so moms of little girls, they get very scared when they see that. But you just sit down with them and explain to them what's going on, and it does go away. As soon as the baby is able to break down those hormones and excrete them, then she's on her way. She don't have any more of that. Okay. And you always want to give a mom, when you're doing teaching, cleanse the vulva from the urethra, okay, back down to the anus to prevent any kind of fecal matter from entering the urinary meatus. Because what it does, it leads to a urinary tract infection. You don't want to do that to a little girl that's just, her glomeruli is small and her emptying is different. You don't want to do that. Okay. That's why, as an LPN working in a, say, mother-baby unit, you are so great to sit down and take the time and explain things, because that's what you do. Part of your scope of practice is you're reinforcing the teaching that has probably occurred, and you're reinforcing that to the patient. Now, getting to the skin. Okay, so it's an integumentary system. So you're going to look at the overall skin condition of the baby. Okay, is it dry? Is it peeling? And then the turgor, just like you would with an adult, we look at skin turgor, and we'll look at that, and we'll look at again the skin condition. I would definitely write this term down. It's called Lanugo, Lanugo, and these are little fine hairs, and they protect the fetus when he's inside mom's womb. Okay, and as they get closer to term, it goes away. It disappears. It goes into the amniotic fluid. Baby sheds it off him. So that would be a good test question in exam 3. So I would take note to that. And then another good test question would be about Vernix Caseosa, which these are made of cells and glandular secretions. And it's thought, but it really does a good job to protect the skin from irritation and effects of a watery environment. You know, just think, okay, when you go in to swim, like when you go into a pool, all right, or an ocean, and you're out there for like a long time. I love to swim. So when I get in the pool, I'm there for hours. All right. When you come out, what does your skin look like? All right. It's what, all wrinkled up, right? Because you don't have any protection. Because when, you know, especially in a pool environment, they want you to take a shower before you even go in the pool. So you have no protection for your skin. You come out, you're all wrinkled up and sometimes even peely. So again, Vernix Caseosa, when baby's in utero and he's in all that amniotic fluid, okay, this stuff is able to protect him. So when he comes out, his skin is not all wrinkly and peeling off his arms. Okay. All right. Now, so I would know that. That's another great test question for exam number 3. All right. Now, physiological jaundice is seen as yellow tinge to the skin. And what happens is that you have, you know, you're having, you know, blood circulating, right? So the baby has a lot of red blood cells. Okay. So the liver is supposed to break those down, right? And get rid of it, get rid of the bilirubin. But what happens is you're having this rapid destruction of excess red blood cells. The liver cannot keep up with that. And therefore, bilirubin increases. Bilirubin increases, changes the color of the baby's skin. Bingo. That's it. Now, physiological jaundice occurs in like the first few days, 2 to 3 days after birth. Okay, it makes sense. Remember, the liver is immature at birth. Again, it cannot keep up with a massive amount of red blood cells and the destruction of them. So what happens, that bilirubin goes up, okay? And it takes a few days for all that to happen, okay? So that's why that's called physiological jaundice, and it does happen to babies. And how we take care of that is we put the baby under phototherapy. Now, if we have jaundice in the first 24 hours of birth, after birth, the first 24 of his existence, that's called pathological jaundice, okay? And that's not a good sign. Just like it sounds, when you hear pathological, don't you go, oh, no, that's not good at all, okay? And so that is not good. That means maybe something's wrong with his liver, the baby's liver, and it's not working at all. And so he's showing up as yellow right after he's born. Not a good sign. So here's my safety alert. I'm probably going to repeat myself, but that's okay. Jaundice that appears in the first day of life, okay, the first 24 hours, is not normal and should be recorded and reported, because that's called pathological jaundice. All right, now we're going to go into his GI system. So his GI system, it's immature, but it's functioning, and it begins shortly right after birth. And his first stool, that's called meconium. And I know you know that term. What it is a mixture of amniotic fluid and his intestinal gland secretions, such as Vernix Caseosa, maybe that Lanugo that he shed off before he it's in that amniotic fluid. So it's not a great environment, but he doesn't know any better. So, and he's okay. You know, that's his little home. And so he's doing a lot of stuff in there. But this meconium, if he has it in utero, it does, you know, put the baby more at risk at birth. Okay. So, you know, the first stool is so, it's tar. It looks like tar. It's real dark and it's thick. Okay. And it could be, you know, greenish black even. And basically it's thick. Now, when they have a meconium in utero, and that's where, you know, the baby's will breathe all this stuff in before he's born. That's why we have to suction him at birth right away. And so what happens, the head, so he had a meconium in utero, okay, and just knowing what it looks like, and now he's in utero, you know, it's in water, so he's going to be, you know, circulating in it. And so when he's born, and we see it, we know he did that meconium because when he had, when mom broke a bag of waters, or we did an AROM on her, artificial rupture membranes, we saw that fluid. And then we saw that he already had his first meconium. So when his head comes out, we're going to use wall suctioning and we're going to suction him out. Okay. You know, as much as we can out of the mouth and down. We can't go all the way down because it's, you know, he's not out yet, but we get as much as we can out of that mouth because he's got a lot in his mouth. Okay. Then what happens is we take the baby, we don't stimulate that baby to cry. We take the baby over to the radium warmer, and RT, respiratory therapy, is there, and the NICU nurse is there, and they will go ahead and intubate them, go down deeper suctioning, do 2 passes. They go down once, all the way down, and then you know how you suction, you come back up, you know, using a little hand motion and come back up. While RT is suctioning, the NICU nurse is feeling the cord and counting his heart rate. Okay. And they do that twice. And they get as much as they can because we don't want him to aspirate on the meconium, because meconium aspiration syndrome is a very serious respiratory problem. And so, you know, could lead to a long stay in the NICU and be on antibiotics for a long time. Okay. All right. So again, if he hasn't done it in utero and now he's born, it usually passes between 8 to 24 hours after birth. Okay. And you'll see that. And you need to chart it. Okay. Now, anytime the baby has bowel movement, you're also going to chart it, and you're going to chart the color, the amount, consistency, because you know, the baby stool will be dependent upon how he's fed. Now, breast milk, breastfeeding is the best, because I tell you why. It has all the nutrients. It has the colostrum, has all the antibodies, and then you have milk that, you know, coming in. You got milk that has lactose, has a little bit of fat in it, but it doesn't have too much, but has enough what the baby needs. And baby can digest it a lot easier. Okay, so how about a little brain teaser? The nurse is caring for a large baby of a mom who has gestational diabetes immediately after birth. Okay, so the mom has gestational diabetes. What assessment finding can the nurse anticipate? Remember, okay, this mommy has gestational diabetes. That means she's had circulating extra sugar in her what? In her system. The sugar will cross over to the baby through the placenta, and so babies get a little bigger. Okay, yeah, you feed yourself sugar, you're going to get bigger. So what happens that this baby's born? Okay, so what are you going to see? You're going to see a weight of 9 pounds or greater. Okay, and you might see that one again. So I would definitely write down macrosomic babies are babies who weigh 9 pounds or greater. All right. Now, getting back to the other choices, which would be high blood glucose levels. Well, you might have jumped at that because you're thinking, oh, she has gestational diabetes. But think about it. Once that cord is cut, okay, all right, baby's no longer getting fed sugar. So what happens with these babies, they have the opposite. Their blood sugar goes down. So he'll have hypoglycemic. Okay. So that one was a no. Okay. And decreased subcutaneous fat, no, because he is a large baby, has lots of good subcutaneous fat, because again, he got that extra little fat through the sugars that from mom's being a gestational diabetes. And hyperbilirubinemia, no, it does not go along with gestational diabetes. That has to do with the liver. So anyway, your best choice would be weight of 9 pounds or greater. Okay. Now, heads up, we'll probably see it again next week. So I want you to take note to that. So here's your normal infant stool. See, here's your meconium. So see how thick and tarry it looks, And it does. It looks just like that. And then here, mom's starting to feed. So here, that feeding now is helping to break down that meconium. Because what you put out is what you put into your body, as you all know. So here, mommy's breastfeeding. And so here now, this is called a transitional breast stool, okay? It's getting better, okay? And as she goes on and keeps breastfeeding, remember she's feeding maybe every 2 to 3 hours, 2 hours in the very beginning. And so that helps break down that digestive tract, that meconium. And then here, this is what we call a normal breastfeeding baby stool. It's yellow. Yeah, and that's common. It has sometimes we call it grainy because it has little grains in it. So you want to take note to that. You can see the difference between a cow's milk stool and a normal breastfeeding. This is much better for the baby's digestive system. And here, just throwing in diarrhea and a constipated stool. As we know, got to have feedings and got to have, and in the feedings, babies get enough water through mom's breast milk too to keep them hydrated. All right. So constipation is never good because the stools are really hard. And he had a hard time pushing because his little abdominal muscles are not fully developed yet. So they do have a hard time with constipation. Hiccups are normal. And so we always teach mom to birth the infant and offer warm water. And, sometimes giving a little bit of warm water can help with hiccups. But hiccups are normal. And the digestion, the capacity of the infant stool is only 90 mLs, which is about 3 ounces. So that's not a whole bunch. That's why you have to feed every 2 to 3 hours because one, the breast milk is easily digestible. Okay, so it'll empty his gut a lot quicker than say formula, and you can only give small amounts because he can't handle a whole bunch. If you overfeed a baby, what happens? The baby will bring it back up. And that's uncomfortable for the baby to throw up. So you don't want that to happen. So you have to feed more often. And infants, they may need some extra vitamins, vitamin C and D. But the pediatrician will make that decision. Now, we want to prevent infections because I tell you why, babies are born with 1 month of we'll call passive immunity from mom. And so you want to make sure that you don't take this baby out because his normal response to inflammation infection is slow, okay? So, because again, it's immature. The immune system is immature. Therefore, his response to inflammation infection is slow. All right. So you take them. I see sometimes, especially if a baby's born, say in October or November, I see them in the mall in December having a picture taken with Santa Claus, which has all kinds of germs. Okay. And so anyway, I know that's important to the parents, but they have to realize that this is very, very significant. All right. Now, the umbilical cord stump is a primary site of infection. It has to be kept clean. So as as you're discharge planning, you must go over keeping the cord clean. And you don't need to do a full bath submersion. They can clean the baby, in his body. And then when the cord falls off, because it will dry up, keep it clean, soap and water, keep it clean, and it dries up and it will come off. Okay. Then after the cord falls off, then you can put the baby in a little bathtub never leave a baby alone during a bath. Okay. All right. So again, you want to go over that in your discharge plan. Now, your hand hygiene is the primary means of preventing infection. Now, you might see that's a pretty good test question, or it could be like standard precautions is the best way of preventing infection and spread. So you have these immune globulins, and instead of say immune globulin G, we just say IG and with a capital G. And then these cross the placenta and provide newborns with that passive immunity that I just talked about. It's like really 1 month of good passive immunity. It could go longer, but usually that's what we see. So again, don't put the baby out among a whole bunch of people, strangers, because the baby can pick up germs. Now, the immune globulin M is called IgM. These are produced by the newborn. And then if they have an elevated level, it could be a very serious infection. And so we'll attest to that if the baby is showing signs of infection. Immune globulin A, which is IgA, is produced after the neonatal period, about 1 month. Remember, they're called neonates for 1 month. That first month, that's called the neonatal period, okay? And IgA is contained in breast milk. Bingo. I mean, it's so good. Remember, I told you, I would also write this down. Colostrum produces those antibodies that babies need to protect them from what? Infection. So it does also provide resistance to respiratory and gastrointestinal infection. Big time to baby. If this baby gets a respiratory infection, it can lead to RDS, hyaline membrane disease. It can kill a baby. A gastrointestinal infection, baby doesn't get the nutrients it needs. It can also do some harm to that baby. So we want to make sure that at least breastfeed for the first 6 months to get this baby on his way. Now, before age 1 month, infants are at risk for such infections, and not just what I just said. Very important, because GI infection is hard, and babies would be in the hospital. They would have IVs, and they would be really sick babies, okay? And then they would probably have to have gavage feedings, and so it's very hard. Now, let's go over something, neonatal absence syndrome. Now, I want you to take note to that because you'll see this again very quickly, like next Monday. All right. So this happens when the fetus has prenatal exposure to drugs. Okay. So mom, during a pregnancy, she took opiates, maybe amphetamines, some tranquilizers, or maybe she had some multiple drugs while she was pregnant. Now that all goes to baby. And we talked about this already because it crosses the placenta and it gets the baby actually addicted. We call that physically dependent on the drug. And so when babies are suffering, when they come out, remember, babies are born. What happens? We cut the cord. Okay. Now we're cutting off their drugs. If mom was taking drugs, we'll cut their drugs off. They don't get no more drugs. So they go through withdrawal symptoms after birth. Very nasty, very upsetting. Baby's very irritable, has a hard time breathing. You have to console them. They're not consolable. Okay. And so you have to swaddle. You wrap them up real tight. And sometimes you have to just let them cry it out. And it's horrible. And they can have seizures too. So what happens is, I wrote this for you so you could have it. So what symptoms will the baby exhibit? As I said, tremors, hyperirritability, very irritable, very. Those are the principal signs of the condition of the newborn. I would write this down. Tremors and hyperirritability, okay? So they also will show you they don't sleep. They're always awake. They have massive diarrhea. They're poor feeders. Remember, I told you sneezing and yawning. Now, I have seen this on a test. So I would really heads up, okay, and write this down. So the newborn, in addition to having tremors and hyperirritability, okay, they're not consolable. They are fully awake all the time. They have diarrhea, so it affects the GI system. They don't want to feed, okay? They're poor feeding because their body's looking for the drugs. They have sneezing and yawning. Okay. Now the treatment. Well, we have to put them in a quiet environment. And I told you we had to swaddle the infant up real tight. And you have to reduce any kind of external stimuli, and you watch for seizures. A lot of times we'll put them on phenobarbital so that, for the seizures. Again, the treatment, you're going to wrap them up real tight. You're going to give them a quiet environment because any kind of external stimuli will make them more awake, okay? Make them more hyperirritable, and you don't want them to have, tremors and then eventually have a seizure, which can happen very easily. Okay. So now your baby is going to go home. So this is your discharge planning and patient teaching. Now, one of your discussion questions, or no, it's not discussion question, is your teaching plan. You can do a discharge planning, okay, and parent teaching. So you can, get a lot of information right out of your own book, and make sure at the end of your teaching plan, you put your reference. And what happens? Remember, just like any other discharge planning, it begins upon a mission, right? Yeah, always, okay? And the areas to include would be your basic infant care. Okay, so you want to go over bathing, cord care, circumcision care, feeding, and elimination. Real important. This is your basic infant care. Then you have some safety measures. You want to make sure mom's well aware of the SIDS, so proper positioning for sleeping on the back, right? On a firm mattress. And then immunizations. Make sure that you get a hold of a pediatrician for them. And we actually can make appointments right from the hospital for their immunizations. I mean, they'll get like a Hep B, they'll get like vitamin K, and they get their erythromycin eye ointment in the hospital. But they're going to have, now they have to go and have their regular vaccines. And then return appointment for well baby care. Yeah, so these two, you can actually make appointment for their pediatrician. Because a lot of times, remember when she was on mission, the laboring mother, we asked them about the pediatrician. And we say, who's your pediatrician for this baby? Because we know we're going to get them appointments for the well baby care. We got to make sure that they are seen. And then the car seat. Babies cannot go home unless they have a car seat. Okay. And years ago, the nurses, actually, we used to make sure that we put the car seat in the car, but we don't do that anymore. No, the parents are responsible, and they can go, part of the prenatal care was we go over that car seat, okay, because we know how important it is to have a car seat in the car. Okay. Now, we also go over things that can happen and who they should contact. So like you want to teach the parents signs and symptoms of problems, okay, respiratory problems, temperature, baby is not feeding well, he has the persistent forceful vomiting, and maybe he's not urinating or having a stool. Those are all very important problems to report. And a temperature greater than 100.4 by axillary is not good. So again, these are things we go over. And on our discharge plan from the hospital, we go over every single one, and we check it off every week. We educated mom and dad, and they check it off, and they have to sign that discharge plan. And home care, make sure now they're home feeding, They need to eat every 2 to 3 hours. I talked about that. And then they may wake up crying. And so you want to assess that they have a wet diaper, clean the baby, get the baby in a good position for breastfeeding. Make sure he has a proper latching on. We talked about that in the last chapter. Latching on, has the entire areola in his mouth, and make sure that you teach mom how to break the seal. And so they may have to work. There may be every 2 hours in the very beginning. Because remember, the baby's stomach only can take, 90 mLs, 3 ounces. And so you're going to have a baby waking up. It's demanding. Yes, it is. But we go over the benefits of breastfeeding very, very specifically with the parents. So not only they're well informed, okay, and they know how good it is for the infant to get these immunoglobulins for their immune system. Make sure that they have a safe environment, okay? Don't need a bunch of furniture. Don't need a bunch of stuffed animals. No. Empty crib, good firm mattress, and free from all kinds of blankets. No, we don't need all that fancy stuff. And we want to make sure his clothing is soft and washable. And they have those onesies, and you don't have to use even blankets. They have onesies where, they're warm and they're able to be that's one way being covered at night. My baby moves around, he doesn't suffocate with the blanket. And then let's go with skincare. Baby skin, very fragile, very soft, and so you want to make sure you do good skincare. Okay, well, that comes the end of chapter 12. I hope that you take the time to read the chapter, and I hope my little presentation helped answer some questions you might have. Okay, so be sure to go over, the different areas: respiratory distress syndrome, sternal chest retractions, that macrosomic baby, big baby, 9 pounds or more. Remember, go over Caput Succedaneum, whereas the cap is in the back here, and it does cross the suture line. It's okay. If you need to put your hand here, okay, and say Caput Succedaneum, okay, yeah, that's right. It would cross the suture line because it's right here, because here's the sutures. Cephalohematoma on the side does not cross the suture line. It's a blood clot under the scalp of the head. Okay. So that's kind of neat to kind of help you along to remember. And then RDS, respiratory distress syndrome. What is the baby lacking? Remember that very important enzyme is called what? Or protein. It's called surfactant. And rooting. Remember the reflexes. Really, really important. Neurological system is working good. And one good reflex is for the baby is rooting, so that baby, I'm trying to find mom's breasts. Okay. And then of course, don't forget some other important parts of postpartum care. If the bladder is full, what are you going to do? You got to empty it, because a full bladder, remember, bladder lays right underneath the uterus. Okay. And a full bladder push that uterus up and makes it what? Go over to the right, deviate. It's a deviation of the uterus. And the uterus, after she delivers, the uterus must be midline and at the level of her belly button, the umbilicus. If it's anywhere else, if it's pushed up and over, you got to think bladder, because the bladder is pushing. So empty her bladder, or ask the patient, would you like to use the bedpan? Okay, you get her devoid. All righty. And then, of course, we talked about neonatal absence syndrome. They have, as you can review it on your own, they need to be swaddled. Okay. They need a quiet environment, not too much stimulation, because they tremors, they're really irritable. They don't sleep. And so they could have seizures. So you just want to keep them what? Quiet. Okay. Once you get a baby that's addicted to opiates and they quiet down, it's like a blessing. Believe me, I have taken care of a lot of babies that were delivered from a drug addicted mom, and it's very sad. Okay. It's bad enough to see an adult go through withdrawals, honestly. But when you have a baby that he's so innocent, and meanwhile, he's suffering so much when he's born. Okay. Well, that's my little soapbox, but that's how I feel when I take care of my babies. All right. And then don't be sure that you review, don't forget postpartum hemorrhage. It's always bad, right? So you want to always check the mom's fundus to make sure she's nice and firm. Okay. Now you're going to check her peri-pad to see if she has any clots. Because you gotta act on that very, very quickly. Postpartum hemorrhage is what we call an obstetrical code. And we call it PPH. We'll call it out. We'll ring the bell and we'll say PPH1 in room 2, PPH in room 2. And the whole team, guys, honestly, the whole team comes in and everyone has a role. Okay. And it runs beautifully, just like any kind of cold blue, cardiorespiratory arrest. It works wonderful, and we can get her stabilized very quickly because you can lose a patient. All right, and a uterus without tone is the uterine atony, ATONY. It just doesn't have tone. So I'm going to make sure I'm going to massage that fundus, and I'm going to make sure her bladder's empty, and have that baby to breast. Okay, yeah. You know why? You're probably thinking, why does she say that? It's because when babies are breastfeeding, they produce they say a signal to mom's brain to produce oxytocin. And as you know, oxytocin is produced in the anterior pituitary, and it makes the uterus contract. Bingo. So if you got a patient that is having some problems like that, put the baby to breast. All righty. I think that concludes today's lecture, my little review. Hope you enjoyed it. Please read the chapters. Please listen to the PowerPoints and do the Cahoots. All right. A lot of time and effort went into the Cahoots for you, and have fun with it. Okay. Have fun. All right. I'm going to sign off now. It was a pleasure to spend a few hours, maybe a couple hours or maybe an hour with you this morning. Okay. And I'll see you next week. Bye-bye, everybody. Have a good day.